All right, so we'll get started. Hi, everyone, and welcome. My name is Lorraine Hamuka, and I'm a pediatric nephrologist and transplant nephrologist at the Alberta Children's Hospital. I'm very pleased to be moderating today's session. Before we begin, I would like to acknowledge Paladin for their ongoing support of the ATI seminar series. Also, the University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nation, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I am now very pleased to tell you that I would like to introduce our presenters, who are both colleagues and I know very well. First of all, we have Dr. Debo Ademola, who is truly a pleasure to introduce. I have had the opportunity to visit his center in Ibadan, Nigeria, which was an amazing experience. Dr. Ademola is a pediatric nephrologist at the Department of Pediatrics, University College Hospital Ibadan in southwestern Nigeria. He acts as the director of the residency training program for his department. Dr. Ademola's medical training was at the University of Ibadan, and his residence training in pediatrics was at University Hospital Ibadan. Thereafter, he joined the department. He's also underwent training through an International Pediatric Nephrology Association and the International Society of Peritoneal Dialysis at the Red Cross War Memorial Hospital in Cape Town, South Africa. Dr. Ademola is the site co-investigator for the Human Health and Hereditary Study Kidney Disease Research Network, funded by the NIH for a multi-center and multi-country collaborative study of the genetic and environmental factors accounting for kidney disease in sub-Saharan Africa. Dr. Ademola has a research interest in renal replacement therapy in low-resource settings, ranging from peritoneal dialysis to kidney transplantation. Our second presenter is my local colleague, Dr. Julian Midgley, who is a pediatric nephrologist at the Alberta Children's Hospital. Dr. Midgley began his medical training in the UK at Cambridge University and then Oxford Medical School. He continued his training in various hospitals in the UK, including he completed a year of pediatric kidney transplantation at Guy's Hospital in London, UK. Following a nephrology fellowship at the Hospital for Sick Children in Toronto in 1994, he began working at the Alberta Children's Hospital as the only pediatric nephrologist at the time. Since then, we've grown to 6 pediatric nephrologists at our center. In addition to his clinical activities, Dr. Midgley has varied interest in education from medical students to continuing medical education, as well as patient support advocacy, and is a past volunteer president for the Kidney Foundation of Canada. Dr. Midgley is the Congress President for the upcoming IPNA, which is the International Pediatric Nephrology Association 2022 Congress that's taking place in Calgary in September of 2022. So we do hope that some people can attend that. I would now like to pass it on to my colleagues to present pediatric kidney transplantation in Nigeria, challenges and progress. Thank you.
Thank you very much indeed, Lorraine, on behalf of Debo and myself, for your kind introduction. I will share some slides, and Debo's going to let me know when to advance. He'll do most of the talking, which will be a relief to quite a few people. So we're going to talk about pediatric transplantation, really kidney transplantation in Nigeria, challenges and progress. And we're going to talk a little bit about why Ibadan and Calgary, and then Debo's going to talk quite a bit about Nigeria and their experience, and then a little bit of a return to what we're going to hopefully do in the future. So, gosh, nearly 11 years ago, Susan Samuel was at the 6th World Congress of Nephrology in Vancouver and at a satellite meeting, and she struck up a conversation with Debo, and that led to where we are today. Now, you may not know where Debo is, but I've got a map here of that rather large continent of Nigeria. And if we zoom in on Nigeria, you can see Lagos in the south there, and then Ibadan towards the north. This is Ibadan. It's a very good university city, and here we have the University College Hospital right in the middle of Ibadan, and that's where we've visited 3 occasions now. We were fortunate after Susan Samuel had quite a bit of a research interest with Debo to establish an ISN Renal Sister Centre, and they support centres in emerging countries to try and partnership with 2 centres for educational benefits and some funding. And we've moved from the first level of C up to B back in 2020, and now fairly recently we've gone to A, which means that we will take a bit of a backseat, and Debo will start to look for and support other centres and another centre himself as we mature this relationship that we've had with Ibadan in Nigeria. More recently, we've also been fortunate in having been successful in an application for the International Pediatric Transplant Association outreach program, which is a program which helps centres support lower middle-income country centres such as in Ibadan for a transplant program, and that will be talked a little bit about. But before I hand over to Debo, I just wanted to illustrate that Nigeria is rich and poor. There's various articles about how there is a highest gross domestic product in Africa, but there's actually quite a lot of poverty too. And when we put it into context, we also see that because of the very large population of Nigeria, it's actually the sixth gross domestic product per capita. And this is important because money does make a difference, and this is illustrated by a graph from this paper, which looked at how do we achieve global equity in the provision of renal replacement therapy. We can see that there is a relationship between the GDP per capita against kidney transplant prevalence. But there's also some outliers, because we can see that down at the bottom we have some countries where there are relatively large GDP per capita, but very few transplant procedures. On the other hand, above the line we can see some countries which have more transplant prevalence than the line of relatively good fit there. But when we look at the transplants as a proportion of overall renal replacement therapy, we can see that there's less of a good fit. There's quite a lot of scatter here. I've outlined Canada, which is pretty much on the line. But when we look at African countries, and Nigeria is not on this graph, we can see that there's quite a few above and quite a few below. Some places in Africa have a relatively high transplant rate compared to non-transplant renal replacement therapy, and some quite low. So with that sort of setting, we're going to talk a little bit now about Nigeria and transplant there. So Debo, over to you.
All right. Thank you very much, Julian, and we appreciate the ATM for the opportunity to have this talk, and thank you for the wonderful Julian introduction. In Nigeria, the first kidney transplant took place in March 2000, 6th March 2000, at a private hospital, St. Nicholas Hospital in Lagos. And the first pediatric transplant was in 2009, and 6th August at the same hospital in a child who was about 15 years, end-stage renal disease from posterior traverse. Next slide. Next slide, please. Okay. Since then, about 14 different centers now do kidney transplant across the country, and I've indicated these in black dots. And Ibadan is somewhere on the southwest. All right, next slide, please. So following the first transplant, Nigeria has carried out about 450 kidney transplants in 14 different centers. A couple of privately owned hospitals. About 4 of these centers have carried out most of these transplants, about 400. There's significantly less experience with pediatric kidney transplants, and which constitutes about 3% of all transplants done in the country so far. Next slide, please. And then talking a little bit about St. Nicholas Hospital. A lot of these transplants have been carried out in collaboration with organizations abroad. Okay, go on. Next slide, please. And then the income distribution of the recipients show that the majority of the recipients were middle class, a few were high class, and a small proportion low class. Okay, next slide, please. And the income distribution and sources of funds for the patients at St. Nicholas Hospital, personal funds were about 40 of these patients. This was at the time when they had carried out about 137 transplants. Sponsors were petroleum companies in about 29 patients. Government paid for the transplants in about 16 patients, and private companies in about 14, public appeal about 13, some churches in about 9. Okay, next slide, please. So some of the challenges that have been noted in transplants in Nigeria is that usually when the centers are starting, there's some skepticism on the part of patients to participate. We've had issues with HLA typing, cross-match in the pre-transplant workup. Usually when transplants started in Nigeria, samples needed to be sent abroad. There's some centers in Nigeria where we can send samples now, though some programs still send samples abroad. And monitoring of the levels of immunosuppressive medications sometimes is a challenge because sometimes that's not available locally in the hospital where the transplant is taking place. Donor issues, and I'll talk more about this. Then histopathology services also needs to be developed for that. Very, very, very few renal pathologists in the country. I met one recently. And then the cost of kidney transplantation, maintenance immunosuppressive medications, and the very low number of pediatric kidney transplants. Next slide, please. So this is an article that was published about a year ago or 2 years ago. 22 pediatric transplants had been done in the country between 1986 to 2019, or were managed in the country pediatric. About half of these children got their transplants abroad, and about the other half were done locally. And there was no difference in outcomes in whether the transplant was done abroad or locally. But at the time of this writing, about 4 of the 22 children had died. Most were the 3 of them were because they didn't have money for maintenance immunosuppressive medications. Next slide, please. So the burden of CKD and end-stage renal disease in Nigeria. In the adult population, in various studies, burden of CKD ranges from 7.8 to 33%. End-stage renal disease accounts for 10% of medical admissions, and deaths from renal causes constitute about 22% of medical deaths. In the pediatric population, end-stage renal disease is about 4 to 6 per million age-related population. In the UCH Ibadan, modestly, we'll see about 7 to 10 new cases per annum. There could easily be up to 13 new cases per annum, mostly secondary to chronic glomerulonephritis, nephrotic, non-nephrotic, and then congenital anomalies of the kidneys and the urinary tract, posterior atrial valves being the most common. Median survival following end-stage renal diagnosis, it's about 47 days in the absence of kidney transplantation and chronic dialysis program. So most children will die within 50 days of the diagnosis of end-stage renal disease. Next slide, please. So kidney transplantation in the hospital, UCH Ibadan. Experience is limited in the adult population. We operate a public institution. The dialysis program has its challenges. And transplant services are subsidized by the hospital, especially when we were starting. We've done very few when we're starting. And then even now, the hospital waives admission fees, the bed fees for transplant patients. Next slide. So transplant services commenced in 2008. Took a few months to do the first set. Cost approximately about 24,500 Canadian dollars per patient. It's living-related donor, disease donor program hasn't taken off in the country yet. We're yet to start pediatric kidney transplantation locally. We offer acute PD, intermittent HD, mainly acute. Estimated cost of kidney transplantation in children will be about 31,000 to 37,000 Canadian dollars, because for the children, we may need basiliximab and anti-lymphocyte antibodies globally. Next slide, please. All right. This is about the donor living related. We can move on to the next slide. So the first transplant in UCH was 2008, another one in 2009. We had two in 2012, 2016. The last was just before the COVID in 2020, and he's still alive and he's doing well. So we had in 2020. All right, next slide. So to focus a little bit on the patient that had kidney transplant in 2016, the adult patient. She was an undergraduate in the university. She had very difficult to control blood pressure, BP near normal after transplant. The funding was raised by our fellow students. They went on social media, public appeal. The state, Ocean State, donated generously. The donor mother is still alive. She died about 4 years post-transplant. She died in 2020 because she could not sustain her immunosuppressive medications. Next slide, please. In terms of in the pediatric unit, we had two patients who had kidney transplantation, went to India to get their kidney transplantation, two of our patients. So first was a 15-year-old boy with end-stage renal disease from posterior retroviral valves. The donor was the mom. The funding was through public appeal. They went on the newspaper, the television, that the child needed transplant. And then she came back, he came back, got the transplant, did well initially, but was irregular follow-up, died about 3 years post-transplant, presumably because the drugs became irregular, the medications. The other girl was the 13-year-old girl with end-stage renal disease from chronic GN. The donor was the dad. The sponsor was the uncle. She died about 5 months post-transplant. She stopped the immunosuppressive medications, and the dad, the parents were unable to afford the cost, and the dad was reluctant to go back to the uncle for more funds. Next slide, please. And then we had a girl, a 13-year-old girl that was admitted in 2018. She was getting tired easily. She had reduced urine output. She had altered sensorium. There was positive history of death from end-stage renal disease in a sibling at the age of 10 years, and maternal aunt who was died at about 40 years. Next slide, please. So when she presented to us, she weighed 24.3 kg, 66% of expected for her age. Her height was 142 centimeters. She was breathless. Respiratory rate was 40. She had hypertension. Her blood pressure was 140, 120. She was lethargic. Next slide. So urea was 42.3 millimoles per liter. Creatinine was 1,264 micromoles per liter. She had bilateral grade 3 renal parenchymal disease. Her kidney measurements were shown there. The kidneys were shrunken. There were no pelvic ileal or ureteric dilatation. Next slide. So she had antihypertensives, diuretics, erythropoietin. She was started on kidney replacement therapy. She had 16 sessions of HD over about 6 weeks, and then she was discharged and continued to have transplantation, initially with us on outpatient basis, and then moved to another center where she was getting her hemodialysis on outpatient basis. She was scheduled and was being worked up for kidney transplantation, but we had challenges. She died July 2020, 20 months after the diagnosis of end-stage renal disease. All right, next slide, please. So some of the challenges we had with her were cost of the pre-transplant investigations, and we got some donors. So we're able to get around this through donations. And then cost of transplant medications. And then there was a philanthropist that came and she was willing to support. But the parents were concerned about post-transplant medications, maintenance, immunosuppression. Initially, the dad was going to donate, but later the father actually declined because he felt like the girl would not do well after transplant, that they may not be able to maintain immunosuppression. So he didn't go ahead to donate. He declined. So the child continued on maintenance hemodialysis and died, like was said previously. Next slide, please. So a paper from a nephrologist from our center on donor issues regarding kidney transplantation. Can go on to the next slide, please. So with us, pre-transplant workup for donor and recipient will be between 1 and 1.5 million naira. That's about 3,000 to 4,500 Canadian dollars. The HLA typing for donor and recipient will be about 320,000, about 980 Canadian dollars. Cost of transplant surgery and immunosuppression for about 3 months, it's about about 20,000 Canadian dollars. And cost of maintenance medications modestly will be about 300 to 500 Canadian dollars per month. Okay, next slide, please. So other challenges are drug level monitoring and turnaround time. But we actually have the equipment for this in our hospital, and some of the private laboratories have in fact even slashed down the prices from 110 to 55. So this is becoming easier. I imagine that when the number of transplants go up, this will take place more frequently on site. But as of now, there's some challenges with that. HLA typing and cross-match. In our hospital, we actually have the equipment, and we're also looking to get the training. And then there's some centers that do HLA typing, cross-match in the country. And we also have the potential to send samples outside the country through collaborations. The diagnosis of viral infections is a challenge, but this is becoming easier because facilities for PCRs have become more widely available. Unfortunately, we had the COVID pandemic, but this is something that has come out from the COVID pandemic. So ability to diagnose viral infections. So what I'm told is that what we need more are the primers, the equipment that are more widely available. And transplant pathology, we need transplant pathologists. I met one in a nearby hospital, Nigerian, recently who trained, but we need more transplant pathologists in the country. Then challenges with chronic dialysis in children, sometimes getting consumables that are appropriate for children, like tunneled vascular catheters to maintain them on dialysis, can sometimes be a challenge. Next slide. So I sent out a survey and grateful to some of pediatric nephrologists and others who completed the survey and about transplants, pediatric transplants, and the challenges that we have. So, and most of the people who responded were working in government hospitals. Next slide, please. So, mostly pediatric nephrologists, consultants, and one intern. Next slide. Next slide. And they were from 6 of the transplant centers in the country. 6 of the centers who carry out transplants, 6 of the 14 centers were represented. Next slide. About 57 of those actually carry out kidney transplantation in adults. 57% of those, well, of those responses were from those centers. Next slide. Numbers were small, and the numbers of transplants that have been carried out in the various centers were small. Well, there was one that had done over 60, that's Kano, Nigeria, and Zenith Medical Center, Abuja, they had carried out 357 transplants in mostly in adults. Okay, next slide. So how old was the youngest patient who received kidney transplantation in your hospital? So one center, the youngest was 10 years. The others, the youngest were people who were in their 20s, were the youngest. Next slide. And about 71.4%, well, out of the 7, about 6 actually managed children who had received kidney transplantation, whether in the country or outside the country. Next slide. All of them were managing children who needed pediatric transplantation at the moment. So the question was, if you're currently managing a child who needs transplantation, and all the respondents were looking after kids who needed transplantation in the various centers. Okay, next slide. And some of the challenges they identified were cost of the transplantation, the challenges with donors, the need for surgical expertise, need for medical expertise, limited availability of chronic dialysis and long-term dialysis, cost of medication, need for nursing skills, renal dietitians, facilities, need for political will from the government, cost of transplant medications. Next slide. And some of the suggested solutions were advocacy, awareness, all tiers of government directed towards government, the public, international community, and the need for subsidy, insurance, government funding for pediatric patients, capacity building, training of personnel, facilities, need for facilities, public policy on organ and kidney transplantation, and cadaveric disease donor transplantation, need for registry of renal disease, potential donors, improved access to medications, networking locally, internationally. Those were the highlighted potential solutions. Next slide, please. And we have this partnership, wonderful, and between UCH Ibadan on the right and Alberta Children's Hospital, and we've collaborated, and we are collaborating on the ISN, Sister Renal Centre, and the IPTA, and then the IPNR has also sponsored some of the programs that we have had. Next slide, please. And that is Dr. Julian with the CEO of the University College Hospital, Professor Ted Bayo, on one of the visits. Thank you. Next slide, please. I want to acknowledge that some of these slides are from Dr. Van Bowie, consultant nephrologist in Nicholas Hospital, and to acknowledge all centers in Nigeria carrying out kidney transplantation in both public and private, and all the pediatric nephrologists that look after these children and passionately interested in improving the care of these children. And some of them are here today, and the pediatricians. So I'll hand over to Julian. Thank you very much to the ATM for the opportunity.
Thank you very much, Debo, and that gives people a good idea of the state of play in Nigeria for kidney transplantation, with very few pediatric patients receiving transplants, such as one you see on the screen. And so I thought that I would just take a few minutes to talk a little bit about barriers to kidney care. There's quite a lot of information out there, but I chose this particular publication. It's an international survey led by the International Society of Nephrology in 2016, who were trying to assess the current capacity of kidney care worldwide. And they had a large number of countries, 116. I don't think Nigeria was within that number. And some of the highlights were that 36% reported chronic kidney disease as a government health care priority. And this priority was associated with the country having an advocacy group of one sort or another. But what was interesting is that the percentage that had support for acute kidney injury was much less. And so the 19% of government healthcare priority for AKI was somewhat lacking. And the barriers that this report suggested was what Debo was talking about, sometimes patients and their knowledge and attitudes. Physicians, for sure, and geography was an issue too. They highlighted that for general kidney care, not particularly perhaps transplants, but the guidelines should be feasible and distributed and available. So one would have thought that guidelines should be available relatively easily now, but I think the issue is probably more feasibility within the country in question rather than the availability, although I think it was about 10 or 15% of countries really didn't have the availability of guidelines. And their idea was to increase advocacy, especially for acute kidney injury, because it is a predictor of chronic kidney disease, and to try and increase awareness and strategies to better guide kidney care. So this report really had three main recommendations for action. Increase the prioritization of kidney disease, which in some ways is a governmental responsibility. You need support for chronic kidney disease paradigm. And this is something which was highlighted by Debo. The strong association between advocacy groups and kidney care was highlighted, and there may be some supporting organizations in Nigeria, but perhaps Kidney Foundation of Nigeria would be useful too. And certainly to raise the awareness and adoption of guidelines for kidney care, which perhaps resides within medical organizations and healthcare providers. So where are we going to go in our relationship between Calgary and Ibadan? The next steps are really to talk a little bit more about the needs. Clearly, equipment is crucial because Debo may have hemodialysis machines to maintain patients before transplantation, but may not have equipment. Peritoneal dialysis is difficult because there's really a lack of facility to manufacture peritoneal dialysis fluid in the whole of Africa. We need to establish more multidisciplinary aspects. The idea is to try and get people who have expertise in Alberta and Calgary, such as tissue typing labs, nursing, pharmacists, and all the host people that are needed for a successful kidney transplant. Debo has visited Calgary, but we're very keen to have other people visit, perhaps in the wider multidisciplinary team. Clearly, travel has been rather difficult in the last 2 years, but we hope to establish that. But in fact, visits have largely been replaced over the last year with rounds such as this and other rounds within the hospital here that Debo and his colleagues can join to get some information about how things are being done. So we've had educational workshops in Calgary, which have worked very well. And hopefully we will re-establish this in person, going to Ibadan to do teaching and increase expertise. And certainly advocacy and policies, the local and national government, community support I've talked about, the idea of perhaps of a kidney foundation in Nigeria, and I really want to acknowledge the fact that the hospital administration we've met with each time we've been to Ibadan have been very supportive of the increased efforts that Debo and his colleagues have made in establishing kidney care in their hospital. So the goal, of course, is a successful kidney transplant. It's something which is relatively routine in Canada. We have a patient, a 3-year-old, who had a transplant this week. Creatinine was 500 and now is under 100, just the next day after transplant. We want to see a few complications, and that is difficult because they do occur. We want to have enduring kidney function, and clearly maintenance immunosuppression has been highlighted by Debo as a big issue, which is taken for granted that patients in Alberta will have a supply of medications paid for by the government. Clearly that's not the case, and families have to have a plan and try and maintain that as best as possible. But the GDP per capita is certainly an issue because of a skewed to part of the population in Nigeria. We can establish better quality of life for a recipient, and we can have a different chronic disease, but it is certainly compatible with a productive life. We certainly hope that chronic kidney disease treatment, including transplantation, will become more available and successful in Nigeria in due course. My last slide is really a little shout out to Susan Samuel. So she met Debo, and here they are together at the Nigerian conference that we went to for nephrology. And Susan met Debo, struck up a conversation, and it's through personal communication and personal relationships that relationships between centres in the world can develop. And hopefully we will be furthering kidney care in Nigeria for the betterment of the population through the excellent work of Debo and his colleagues in Nigeria. So I'm going to stop sharing now, and we've got lots of time for questions if there are any.
Yeah, thanks to both of you. That was wonderful. Overview and very interesting talk. Both of your talks for highlighting the struggles and differences in transplantation that exist, and certainly the things that we take for granted at our centers. I certainly would like to open it to questions now. Does anyone have anything that they would like to ask? Feel free to open your mic or type away in the chat. If not, we did have a pre-question that was sent from Uchenna Ibello asking, I would be interested to know how transplantation is financed in Nigeria. So I think, Debo, you did address that somewhat in one of your slides, but did you just want to do a little bit more of an overview? Are you able to unmute?
Yes. Transplant is mainly out of pocket. There's an insurance, national health insurance, but it doesn't cover transplant. And patients pay out of pocket. So patients who can afford transplants will pay for it, but many people are not able to afford transplants, only a very small fraction. So some people will go on public appeal to raise funds, social media. A few people, maybe an oil company, if they're working in a company, may sponsor. In some instances, the government may provide sponsorship, but it's not routine. So the person may have to approach the government and then tell them reasons to support. So it's not routine. So payment is largely out of pocket for kidney transplantation as of today. But things may get better. Okay.
Wow. Yeah. Tough. Okay. We do have another comment. I think I'll read this one first and then I'll go. I see someone has their hand up, if that's okay. Right. So it's from Andrew Masood. Outstanding efforts and a great body of work to maintain consistent performance of kidney transplantation. Question one, are there any current plans to establish a living donation support program in Nigeria? Maybe do you want to take that one first and then I'll tell you question two after?
Well, the awareness of kidney transplantation is growing. The awareness of kidney disease is growing. And I spoke with a doctor who works in a center that carries out more adult transplants and says that they've got this group. I mean, it's starting like a WhatsApp group of people who have had kidney transplantation who are coming together to talk and help themselves and solve their problems, some of the problems in a collective way. We don't have, and then we've got the societies, the nephrology societies who are pushing the cases. So what I'll say is that awareness is growing. We don't have an organization yet that is, but we do have a transplant society. So there's a Nigerian transplant society that's pushing to improve transplantation. So the answer will be yes, we have organizations who are pushing to improve kidney transplantation in the country. So that would be the appropriate answer. Yeah.
Great. And then question number two from the same person, any insights on the potential collaboration with the Canadian Transplantation and Donation Societies? Do you want to?
And Julian can. So we're open and willing for support for collaborations that will advance, improve the care of children with end-stage renal disease in the country. Yes, so we're open. So we're very much interested in that.
Yeah, and I don't know if Lori wants to say anything about that, but at the level of the CST, the pediatric group, I actually recently, just the past president, just recently, I was the chair for a while, and we've talked about doing some connections with other centers, both on an educational and supportive. So Debo, me and you haven't connected for just a bit of time, but perhaps we can do that at some point in time. Lori, did you have anything you wanted to say from your perspective?
No, I think you've covered some of the issues so well, all of the speakers and you as well, Lorraine. I think that some of the national programs as well as possibly the provincial programs would be very interested in looking at what kinds of opportunities would be available, especially, for example, for educational format programs and so on. But I think it's certainly a compelling problem and one that would be hugely beneficial, I would have thought, for collaborative efforts.
Mm-hmm. Yeah, so we'll work on that, and I will bring up your center again. I see that Dr. Azanabi has hand up. Did you want to go ahead and ask your question and mute yourself?
And Dr. Snowy is the head of our pediatric nephrology in UPH. Yeah.
Thank you very much for the opportunity. I want to say a big thank you to our colleagues in Canada, led by Professor Julian Midgley, for all the good work you are assisting us to do in Ibadan. I want to please use this opportunity to appreciate our colleagues who joined us from Nigeria. In the audience here now, we have the president of the Pediatric Association of Nigeria, PNAN, Professor Henrietta Okafor. We have a representative at the International Pediatric Nephrology Association, Professor Ifi Anochie. We have a very senior colleague of ours, Professor Akuse, Professor Adekombi, and many of our younger, enthusiastic colleagues, who attended this program. We all appreciate our Canadian counterparts, and we are looking forward to, further collaborations and the possibility of pediatric kidney transplantation taking off very well in Nigeria. Debo has presented well the challenges we have in Nigeria. So there's no point me repeating all he has said. So I just want to say thank you, and we hope to meet you again. Thank you very much.
Thank you so much, Dr. Asanabi. In fact, I should have, looking through the list here, I do see that we have a lot of people who've joined in, to Nigeria, and I will repeat what Lori has typed in the messages. Welcome to all of you, and we're thankful that you could attend with us today. There are a few more questions that are popping up in the chat, so I'm just going to go ahead and read them out. Iris Cherubin has asked, are immunosuppressant medications paid out of pocket as well? I think I know that answer, but Debo, go ahead.
Well, that's true. Immunosuppressive medications are also paid out of pocket. So that's the reality at the moment. We hope that will change. Yes. Then I also wanted to mention that, okay, Dr. Asanobi is the head of our unit, but she's recently become the president of the Nigerian Association of Nephrology. So that's a few weeks ago. So she's also the president of our renal association.
Wonderful.
Thank you.
Okay, and then we have another question from Henrietta Akafor. Well done, Debo and Julian, for throwing more light on the challenges of transplantation in Nigeria. The burden of CKD is huge over here, so figure quoted are only the tip of the iceberg. So a comment, I don't know, Debo, if you want to add anything to that, or Julian? If not,
I agree. It's huge. So if in one center we're seeing like 10, 12, there's several centers in the country. So the number of kids with end-stage renal disease will be huge. The population is about 200 million. And the numbers, we may be looking at maybe 100 children with end-stage renal disease every year across the country.
Okay, wow. Okay, and then we have an additional statement here from Elizabeth. Sorry, your name's not completely showing up here for some reason. Just going to go back here. Apologies. Elizabeth Marth, somehow your last name is cut off. Sorry about that, but thanks for an insightful presentation. It would seem that the challenges are twofold: inadequate capacity, manpower, logistics, and maintenance immunosuppression. The second seems to be the bigger challenge because long-term survival and productive life post-transplant would encourage all, family, philanthropists, and government would be more willing to fund. What can be done to ensure patients don't die because they can't afford their immunosuppression? And this is certainly something that we've talked about over the years. Like it's hard to give someone a transplant when you can't ensure that they're going to have, the ongoing medication. You're obviously setting someone up not for success. Debo, any headway in that regard, or any other thoughts?
All right. Thank you very much. And the thing is that there's a potential for immunosuppressives to become cheaper when the number of transplants go up. So cost of monthly immunosuppression, when I looked at just a quick look at some reviews, was cheaper in India, maybe South Africa, and all of that per month. I think because of the sheer number of these procedures that are going on. So Nigeria does have the population that can potentially make those medications cheaper after a while. And also, the other thing is the so that on one hand. So at the moment, I think we'll have to look at government to support, and the other thing that contributes to this is the income. So the minimum wage in Nigeria is about 18,000 naira. That would be about 50, about 50 US dollars, about or less per month minimum wage. So that's, and the cost of the immunosuppressive medications will probably be like 150 or 200 or max maybe about about 250 US dollars per month. So those are some of the factors. So I think we're going to think about generics. So that's, and then we're going to continue to think creatively about how to address this issue of immunosuppressives. Does Julian have any comments on what we can do about immunosuppressives? And
it is very difficult, and I would hope that if a transplant is done anywhere in Nigeria, that there's a solid plan for immunosuppressive medications. The idea of bulk purchasing power, or the increased number of transplants, is very interesting. I see Laurie is talking about the possibilities of a Pan-African coordination for purchasing drugs, because people, just the illustration that the cost of immunosuppression medications is perhaps 2 or 3 times the total income in a month for minimum wage. It's just remarkable, and that just it illustrates the almost impossibility of patients, families funding medications for something which is almost routine in many countries in the world, and it's beyond the hope. And it's not surprising that families have a difficult view of saying, I want to give a kidney, but I can't possibly afford, because I can't eat, I can't live if I'm going to pay for immunosuppression. Laurie, do comment.
Yes, I was just putting in too. I mean, is dialysis and other, is that funded through state and government programs? Because of course, in many places, it's been shown to be of economic benefit to save those costs through transplantation. Is there any way of working together on those sorts of approaches?
At the moment, healthcare is primarily out of pocket. So the insurance, the NHIS will pay for about 6 sessions of hemodialysis, but they're not going to pay for more than that. So 6 sessions of hemodialysis, they will pay, but beyond that, patients will have to look for funding. All right, so that may come from going public, making very special requests to government. And so it's not, dialysis is not yet routine. It's not yet routine. Okay.
Yeah, so one argument in Canada is that transplant actually saves money over time. But if dialysis isn't a burden financially to the government, then there's not very much in the way of incentive to do transplants.
Huge challenges, yes. But it would surely be of benefit to return all these people back to healthy, productive, contributing lives by alleviating this burden. Thank you for sharing these challenges with us.
Mm-hmm.
So one of the things I hope we can do is interest people, perhaps on the call, on the Zoom meeting, to say that they're interested in supporting their the same people in Ibadan, in Nigeria. So perhaps the Kidney Foundation, for instance, could be interested in looking at a support group for advocacy to the government. Tissue typing people to help with protocols and things like that. But really, it seems to me that establishing a community support for the paradigm of chronic disease management, including kidney disease and dialysis and transplantation, is so important for moving forward.
Anyone raising their hands to the call out?
Of course, we will be as supportive as we can be. I think there are some comments in the chat about other organizations, and I think this sort of a complex problem on an international level really requires creative thinking and engagement all across across the various possibilities for international cooperation in healthcare. It's really such a compelling story.
Yeah, there are a few comments. I don't know if everyone has seen them, but yeah, there is talk about a initiative partnership idea. I don't know, Tanya, if you wanted to speak about it. Andrew Masood has said a future theme research work that implements co-clinical trial approaches to test potential cheaper alternatives to immunosuppression could provide a hope to maintain transplant and recipient survival. And then Saida has said, is there any contribution from international NGOs to fund some of the medications? Yeah, lots of really good questions, and lots of some ideas. So I think looking at time, I don't know if anyone has any final thoughts.
No, I could just say thank you for opening the door to this discussion and dialogue. And I think I can't speak for everyone, but it seems to me that we'd all be interested in continuing the dialogue and looking at potential opportunities together.
Okay, so thanks again, Julian and Debo. And yeah, we really appreciate hearing from both of you today. I just want to close by letting everyone know that next week our ATI seminar is super exciting as well. We'll be very pleased to have Dr. Bob Montgomery, who will present on xenotransplantation, entitled "Have We Turned the Last Corner?" So hopefully everyone can make it. I think the link will be placed in the chat and for registration as well. So hope to see everyone then. And any last comments, Julian? I see you're unmuted. Feel free. I think if there's a minute or two.
Just forgot to mute, but thank you very much indeed. And I'm really looking forward to further conversations with Debo and helping us. And he helps us because it makes us realize how we work here can help him work there.
Thank you to the Alberta Transplant Institute for this opportunity. And thank you to our collaborators, to Julian, the Children's Hospital. Thank you so much. And to Pediatric Nephrologists from Nigeria, thank you for joining. Thank you.
Okay. Thank you. Okay, bye everyone.